So we are live, so with all your due permission, we are beginning with the session for today.
Sure.
Good evening, everyone. This is Batul from IGCP, and I would like to welcome all the viewers who have joined our platform for the better exchange of knowledge that is going to be shared by our eminent speaker for today's session. Well, he is none other than the very renowned psychiatrist, Dr. Sameer Malhotra, sir. Sir is MBBS Delhi, MD, PGI Chandigarh, CCST UK, CERT teaching, postgraduate in UK, Director and Head at the Department of Mental Health and Behavioral Sciences at Max Healthcare Delhi. So with Sir's wonderful insight and with his wonderful and incredible experience on today, which is World Mental Health Day, we'll be talking about the topic, which is identifying and managing clinical depression. So before moving on to today's session, let us have a brief look on what the topic says. Identifying and managing clinical depression is critical to mental health care. This condition, characterized by persistent sadness and loss of interest, can significantly impact an individual's well-being. Effective strategies involve early detection, therapy, medication, and support to help individuals regain control of their mental health and quality of life. We'll be learning more about the topic with Sir's incredible experience and with his talk. So before moving on to today's session, let us welcome him at our forum and let us hand over the session to him for his enriching talk. So over to you.
Thank you so much. Thank you for providing this opportunity to connect with the fraternity, with my medical colleagues, and particularly so on a day which is very important for all of us. It's the World Mental Health Day, and mental health being a universal right. When I say right, it comes with responsibilities. And that's what we'll be discussing, how to identify and how to manage patients with clinical syndrome of depression. So friends, as you would all know, we use this term depression quite often, even non-medically. We've seen laypersons say we are feeling depressed, I'm not feeling good. Depression, how is it different? How is clinical depression different from a usual mundane word depression that we use day to day in our life? When we talk about a clinical syndrome of depression, remember it's a syndrome, so it has to be a cluster of symptoms. And there are three main symptoms which form the core of a clinical syndrome of depression. The first being sustained sadness of mood. That means the mood is low, persistently low for days, for weeks at a stretch. The second is lack of interest, which we call as anhedonia. Hedonic meaning pleasure, anhedonia meaning inability to derive pleasure out of pleasurable activities. Third is easy fatigability. So when you start feeling tired most of the time of the day, then you feel easily fatigued. You don't feel the energy that you usually have to carry on your day-to-day activities, your mundane duties, your regular rigmarole of life. Then we say perhaps this person could be slipping into a phase of clinical depression. And for diagnosing clinical depression, these symptoms should be present for at least 2 weeks duration, until unless they are very severe, which can make us take this diagnosis a bit earlier as compared to waiting for 2 weeks in the process. Now, out of these three core symptoms of depression, if two are present for a period of 2 weeks, so it's a formula of two of these symptoms present for at least 2 weeks duration, then the likelihood is that the person is suffering from a clinical syndrome of depression. But then there are other cluster of symptoms also which go alongside. One would be reduced confidence levels of the individual. So if you're not that confident in your day-to-day activities as you were before, then again, that becomes one of the important symptoms. Disturbed concentration. So many times our patients would come and tell us that they are not able to remember certain things that they would remember otherwise, that they are making certain mistakes, some oversight errors in their work, which usually did not happen earlier. So they are low on concentration. And when we test them for the memory scales and other parameters, we realize there's nothing majorly wrong with their memory, but surely their concentration is somewhat disturbed. So when we talk about memory, remember it's like a bank. So you store some information inside. So there's a registration of information. It is stored in the head, and then you're able to retrieve it. Just like you deposit a check, the check stays deposited in the brain, and then you retrieve that information. What happens here is that you're not able to register things that clearly. So when we are not able to register things that clearly because the mind is scattered, it is already preoccupied with certain set of thoughts, then you're not really focused. When you're not focused, you're not able to store that information in the right manner. And then when you try to retrieve that information, you're not able to, because you have not deposited your check in the right bank account. So it's not the bank to be blamed. It's not the memory to be blamed. It is your ability to concentrate, which goes a little disturbed when people suffer from depression. What people also go through during a phase of depression is ideas of worthlessness, ideas of helplessness, and ideas of hopelessness. What we say as negative view of the self, negative view of the environment, and negative view of the future. And out of these three, I think the most important could be ideas of hopelessness, because we all can survive through difficult times with this lingering hope in our mind that tomorrow will be better, or tomorrow I'll be able to overcome this problem, or my future is somewhat more secure. But if I start losing hope in future, then one can go through a phase of negative thoughts to an extent of contemplating self-harm or suicide. So thoughts of self-harm, thoughts of suicide also are encountered quite often in patients suffering from clinical syndrome of depression, and so much so that about 10 to 15% of people who suffer from this syndrome of depression are likely to commit suicide. We are not talking about attempted suicide. The numbers of attempted suicide are much higher. I'm talking about completed suicide. So it has to be taken seriously. It should be identified in time. The other ideas that people harbor in their mind during phases of depression would be health-related anxiety. At times, they'll have hypochondriacal thoughts. At times, there'll be ideas of guilt, where they feel that they have committed something very wrong. Although when you dig into those details, you realize it's not that kind of behavior which calls for so much of guilt and so much of remorse. So those ideas of guilt, ideas of remorse are also common accompaniments when we are talking about clinical syndrome of depression. What is also seen is certain biological changes. When I say biological changes, we are talking about significant sleep changes. We are talking about significant appetite changes. And at times there could be significant weight loss accompanying that. So many times our patients of depression would not feel like eating well. They would not have their proper diet. So their appetite goes low. As a result, they tend to lose weight. But there could also be symptoms wherein they start overeating, and there is typically carbohydrate craving for sugars, craving for sweets, and they might put on weight. So we see both elements, whether it could be reduced appetite or it could be increased appetite in a phase of depression. There are certain, when we say biological symptoms, we talk about libidinal symptoms where the libido can be either very low, it can also be quite high. At the same time, when we talk about sleep disturbance, Usually patients find it hard to fall asleep, or they're not able to maintain their sleep wake schedule as they were earlier. And at times there's early morning awakening. That means they start getting up about 2 to 3 hours before their usual time of getting up in the morning. So those symptoms are important, and if they are present, they again signify an underlying biological change through neurochemicals happening in their system. So by and large, these are the kind of symptoms that we see in patients suffering from depression. And one should carefully look into if we are seeing this kind of a behavioral change, this kind of an emotive change in any person, whether working with us in our organizations, whether it's our family, it's our kith and kin, or whether it's our neighbors, relatives, whosoever. We should be careful to be able to observe this change and to help and offer our help to our best possible capacity. The second thing which is important here is to understand that any person who's going through depression feels quite miserable. And it's very easy to say, you are not doing this, that, and the other. You should go for a regular walk in the morning. You should practice yoga. You should be doing meditation. So there are many people who jump into giving advices to people suffering from a clinical syndrome of depression. That person suffering from depression also many a times knows what he or she should be doing. It's like your battery is not charged. Now, no matter how much you shake your phone, it's not going to charge. You need to put it on a charging mode. Similarly, if you're going through a syndrome of depression, you need appropriate treatment. You need a particular way of counseling wherein there's empathic listening. You're listening to the person's problems. You make the person feel understood and comfortable. And you don't push that person too hard, wherein he finds a big gap between what he intends to do and what he's capable to do. When that gap increases, the person's hope starts falling. And when that starts falling, the person starts losing interest in life. So we should be very careful in terms of the language, in terms of the body language, in terms of making ourselves available, and in terms of helping that person to seek proper treatment. What we also see in depression at times are psychotic symptoms. When we say psychotic symptoms, that means the person harbors delusions or hallucinations. Delusions, as you would all know, are false, firm beliefs which are not in keeping with the socio-cultural environment. And hallucinations would be misperceptions or false perceptions without any stimulus. So at times people start hearing voices, derogatory voices, where people have started discussing them in a derogatory manner, that they are not worth it, that they have faltered, that they have been a failure. So they start hearing such kind of voices, or they are a sinner. So when you start hearing such voices, you also become all the more threatened and insecure. So many times when we see patients coming to us with clinical syndrome of depression, it's also important to differentiate as to what kind of depression they are going through. So we use different set of criteria to differentiate. One is based on the number of symptoms, the severity of symptoms, the duration of symptoms. We label them as mild, moderate, or severe. Now, out of these symptoms, like I just discussed, if there's presence of psychotic symptoms, then the person is suffering from a severe episode of depression. We reserve the psychotic symptoms for the severe category. Suicidality can happen even with mild symptoms. It can happen even with moderate symptoms or severe symptoms. So suicidality may not be the factor responsible for diagnosing mild, moderate, or severe. It's the number of symptoms. So if you follow the ICD, which is the International System of Classification for Diseases, they talk about presence of two core symptoms. The core symptoms being lack of interest in activities which are pleasurable, sustained sadness of mood, and easy fatigability. Out of these three, if two are present, and out of the other symptoms enumerated, if two or more are present, we say it's mild. 2 plus 2 is mild. 2 plus 3, two core symptoms, and 3 out of the other listed symptoms wherein there was decreased concentration, decreased confidence, ideas of worthlessness, hopelessness, helplessness. Out of those symptoms, if 3 are present, 2 plus 3 formula, we talk about moderate. If all three symptoms are present out of the core symptoms, and out of the rest 4 or more symptoms are present, we talk about severe depression. And if psychotic symptoms are present, then automatically it gets into the severe category. So based on these, we tend to diagnose. Apart from that, there are certain scales which are used to diagnose and objectify depression. So, and out of these scales, the ones which are commonly used, one is the Hamilton scale for depression. We call it as HAM-D, wherein we take, there are different set of questions which are tapped, and up to a score of, there are about 17 questions which are usually used, and there's some modification in the scale where 21 questions are used. But in that scale, 14 and above would be moderate, 14 to 17 would be moderate, 17 and above would be severe, and more than 10 to 13 would be mild depression. So again, there are different scales which we use. PHQ-9 is another scale which is used, to kind of objectify and the severity of depression to some extent. Now, coming to what should we do? What can we do as clinicians? How to understand, what tests to conduct to be able to understand whether there's any other comorbidity, any other issue, or what could be contributing, what could be responsible for, or what could be maintaining the phase of depression. So herein, it's important to check for blood thyroid profile. This is something which we see commonly disturbed in patients suffering from clinical syndrome of depression. We need to understand if the patient has been on any other medication for any other physical cause, whether the person has been on anti-tubercular treatment, has been on any steroids for autoimmune diseases, if there are any comorbid autoimmune problems, if there are associated psychosomatic problems. We need to understand that. So for that, you need to run through certain tests which are important. Similarly, we need to also check for the complete blood counts, because many a times even anemia can predispose an individual towards lethargy, lack of interest, anhedonia, contributing to the current syndromic picture of depression. Like looking for folate acid levels, looking for vitamin B12 deficiencies, vitamin D deficiencies, they all have a role. And those supplements, as an addition to the mainstay treatment, also are quite beneficial. We talk about two main modalities of treatment when we are dealing with depression, clinical syndrome of depression. One is the talking treatment, the talking therapy. And in that talking therapy, it's very important to listen to the patient, what that patient is going through. Make him or her understand that he's not alone, that we understand the pain that the person is going through. And that part of treatment is also quite important. It's very important to psychoeducate the friends, the family members, and the caregivers, because many a times they don't understand as to why the person has started behaving and emoting in the manner that he or she is at that point of time. So very important to make them understand what the person is going through, and that it is not deliberate, and that it is perhaps arising out of certain set of circumstances, mindset, and some biological factors. So it's an interplay of the environment and biology. So alongside, it's important to make yourself available. So as family, as friends, as caregivers, they need to make themselves available to the patient so that he or she does not feel isolated or alone. Dangerous thing at this point of time is if the person is left to himself or herself, absorbed in those negative set of pessimistic thoughts which need correction. So when that person starts sharing, opening up, communicating, we have opened a channel and we have allowed the negative energy to channelize so that the person is not just isolated and is getting some relief, some solace from others around him or her. There's one myth which is prevalent across cultures. And what we see is that men, and this is what people usually say, men are not supposed to cry. So if a male is crying, that means he's a CC. He's not man enough. Now, these are all myths. Similarly, depression happens to weak-willed. That's another myth in the society that we need to break. We are all human beings and we are all emotional beings. We are all social beings. So as a human being, I think being emotional is a sign of being human. And if you are emotionally disturbed, obviously it is going to reflect in your emotional upheavals. So that person should not feel any weaker than any other individual. Any person can suffer from depression at any phase of life. So we should not be stigmatizing, ridiculing, making fun of, or in our own way, trying to cajole that person unnecessarily. So it's very important to lend a listening ear, being non-judgmental, rather than saying, it's very easy to treat it. Why don't you go for a walk? Why don't you jog? Why don't you come for a swim? It's not easy for a person suffering from a phase of depression at that point of time to engage in those activities, because even the slightest of things appear to be too big for that individual to handle. There are formal support groups. Those could also help in terms of releasing the stress burden by sharing the workload to some extent. As colleagues, as friends, we should opt to help those individuals. Today it's that person, tomorrow it could be me. So we should always keep this in our mind. Helping that person to deal with his or her finances as a family, and all those things are important so that the person gets a little cushioning support during that phase of distress. There are different kinds of therapies or psychotherapies, as we call them, available to deal with patients with depression. So one is the supportive psychotherapy, where we try to offer support. There's more of listening, there's more of comforting that individual and making the person feel somewhat understood, providing ventilation and providing catharsis. Catharsis is when that person emotes while relating that incident, talking about his problems. That person emotes, that person cries, that person weeps. And that is a very good sign of being able to achieve a level of catharsis, so that you are able to release that pressure of emotions inbuilt within yourself. And you are developing that level of trust in the therapist to be able to speak your mind out without being ridiculed and without this fear of being ill understood. The second paradigm of therapies is the cognitive behavior therapy. When we talk about cognitive behavior therapy, quite often it is seen that any person suffering from clinical depression has certain set of negative cognitive distortions or negative thought processes. And if I put it in broad terms, one is magnification. Magnification of negatives. You forget about what positives are happening in your life. You're just focusing on the negatives which are happening at that point of time. And you blow them out of proportion. And you keep thinking about those negatives in your head. The second one is minimization, where you start minimizing the positives happening in your life. The third is dichotomous thinking, where you put a label on people as good or bad, situations as good and bad, but you forget about the intervening, the shades of gray that we see in our life. No life is perfect, no individual is perfect. Too many judgments, too fast judgments, and too quick reactions on situations, on people can rob the fun of life and make us feel depressed, lonely, and isolated. So check for those distortions: magnification of negatives, minimization of positives, dichotomous thinking, labeling. If you put a label on an individual, you then negate anything positive coming from the other end, because we've already put a negative label on that person. The fifth is overgeneralization. So we tend to at times selectively abstract on something which is negative and blow it out of proportion and pass a sweeping statement. So once late, always late. If I'm not happy today, I can never be happy. So a sweeping statement about yourself, about the situation, that makes us feel too belittled and the situation too cumbersome to deal with. That again triggers depressive thought processes and feelings of helplessness, hopelessness, and worthlessness. So it's important to counter these negative thoughts by more positive, challenging, parallel thoughts, which are more rational. So it comes with practice, and that particular therapy, wherein we try to challenge the negative thoughts by more positive, feasible, practical, healthier thoughts, is called as cognitive behavior therapy. Cognitive meaning your thought processes. Then there's another kind of therapy which helps here, is interpersonal therapy. So many times there are interpersonal conflicts, there are marital discords, those things, family discords, those things also lead to depressive mindset. Depression breeds in such circumstances, because there are people who have made misjudgments. They have there's a lot of misunderstanding. There are many miscommunications which need to be resolved. These days, we also talk about mindfulness. When we say mindfulness, we say be aware, be cognizant of what is happening within you and in your environment. But try not to be overreactive and try not to be over judgmental, because excessive judgments, excessive reactions take away the fun of life. So that's something we need to be careful about. Apart from that, the other mainstay treatment is medication. If there's a severe episode of depression, we should not wait. If there are biological symptoms of depression, we should not wait. I'll again reiterate the biological symptoms of depression. They include significant changes in appetite, significant changes in sleep, early morning awakening, depression worse in the morning, excessive psychomotor slowness, or excessive psychomotor agitation, weight loss by 5% or beyond. So when significant libidinal changes. So if those things are happening, we say these are biological symptoms of depression. You need to treat them quick. What are the underlying factors when we are talking about biological symptoms of depression? We are talking about the neurochemistry of the brain, wherein we say that there's this monoamine hypothesis where we say that the monoamines go low in our system. So low levels of serotonin. That's the reason why there are medications called as SSRIs. They are medications which basically target the serotonin system to improve the flow of serotonin across the nerve cells to be able to help you treat depression. Apart from serotonin, the other neurochemical which is commonly implicated is norepinephrine. The third one is dopamine. Let me try and explain their roles a little bit for us to understand it in a better way. Serotonin is important for sustaining motivation, for clarity of thought, for decision-making capacity, for giving you that motivation and zeal, for making you feel good. So it's your happy chemical. It helps you filter the negative thought processes. Many negative thought processes automatically die their own death. They do not reach our conscious awareness 24/7. But if the serotonin is going weak in our system, then those negative thought processes start propping up and we are thinking about them. There's fixation of thought. There are negative thoughts which get fixated. That's again because of low levels of serotonin. Coming to the role of norepinephrine. Norepinephrine is important for energy, for stimulation. So people who are feeling very lethargic, they are feeling very low, they are losing on energy, there's easy fatigability. There, the role of stimulating norepinephrine also helps. So we have category of medications called as SNRIs, serotonin norepinephrine reuptake inhibitors, which do help in the process. We talk about dopamine for people who are very low on motivation and who have become very dull and there's significant psychomotor retardation. In such cases, dopamine boost also helps. Some of the SNRIs, when given in a slightly higher dose, work towards stimulating the dopamine also. So when we talk about venlafaxine, which is an SNRI, till a dose of 150 milligrams in a day, it works more like an SSRI. When we increase the dose from 150 to 225, in that dose range, it works as an SNRI. And when I go beyond a dose of 225 milligrams per day, it also stimulates the dopamine pathway in a way. And when I talk about reuptake inhibition, many times I hear this from my medical colleague friends. They say, when it's reuptake inhibition, how is it improving the flow of the neurochemical? It's because in all of us, in all our systems, in the brain, there's a release of neurochemical happening, and whatever excess remains in the cleft, in the synaptic cleft, is reabsorbed and destroyed by our system. But in people who are healthy, who are mentally fine, doing well, not depressed, those cases, the flow of serotonin is quite good. So the release for the subsequent nerve cells to gather it and then move on is good. But in whatever excess remains is reabsorbed and destroyed. When we are talking about people suffering from a syndrome of depression, the pace of reabsorption and destruction is faster than the pace of release in a way. So there is a deficit of serotonin in the cleft. As a result, they need serotonin-specific reuptake inhibitors, or SNRIs, which include serotonergic norepinephrine reuptake inhibitors. There are many medications that we have to choose from. We have the old genre of tricyclic antidepressants. So you've heard of drugs like medications like imipramine, clomipramine, prothiodyne, dothiopen. So those medications are the tricyclic antidepressants, including nortriptyline and amitriptyline. Every medication used for depression has its own benefits, and there are certain set of side effects. And one has to be a little familiar with their field, with their effect and their side effect profile to be able to help the patient to the optimum best, because you have to tailor the medication according to the profile of the patient, the needs of the patient. There are other treatments also available for depression, which also include RTMS, which is repetitive transcranial magnetic stimulation. People talk about magnetic stimulation these days, which is also helpful in certain cases. This is magnetic stimulation, so there's no direct electric current here given to the brain. It's like directly tapping the brain of the patient to improve the flow of neurochemicals across. The prefrontal cortex is the area which is usually utilized in such therapies. They can even be given to pregnant females. Then we have electroconvulsive therapy, which is reserved for patients who are extremely suicidal or actively psychotic, wherein we need to immediately correct the underlying depression. For patients who are quite suicidal, even lithium or perhaps there are certain medications in psychiatry which are reserved for suicidal patients. Lithium is one of them. But then one has to carefully monitor for both the side effect profile as well as for the efficacy and the benefits that the patient is gathering. Patients with depression should not be left alone. Families should be made aware of their day-to-day experience with the patient and how to be observant and how to keep a cognitive vigil. At times, we have to make sure that the family members keep the medications under their custody so that the patient does not overdo, particularly so if there's a suicidal risk factor involved. It's very important to instill hope, and it's very important to instill faith and patience in patients suffering from depression, and they need that hand holding. So let's, friends, join our hands towards this endeavor, for I think each day has to be celebrated as a mental health day, not just restricted to one particular day in a year. If we are cognizant, if we are aware, if we have that sensitivity, a sensitive eye, a patient listening ear, a non-judgmental approach, and we have the skill and the knowledge base with respect to the choice of medication, we should be able to help our patients the best possible way we can. Because remember, no person, no family, and no society is immune to depression. Alongside, there are many good practices which we should inculcate, whether we talk about yoga, whether we talk about regular sleep-wake cycle. These days, I see children very young, hooked on to their mobile phones. I go for certain mental health programs across schools, and this is a common complaint coming through both teachers, parents, in those sensitization workshops, that this has become an addiction. And it becomes very difficult for them to sleep in time. And if you don't sleep in time, your mind and body is not refreshed enough. And that is reflected both in psychosomatic symptoms as well as in depressive symptomatology. So it's very important to have a healthy, balanced lifestyle. Give some time to yourself. As clinicians, we tend to forget our own self. We don't do justice to our own self. But remember, charity begins at home. So take good care of yourself, sleep well, eat healthy. Visit friends and family without purpose also, just to enjoy and engage. And I think that really helps, because at the end of the day, we are all human beings, we are all emotive and social beings. Prayers help, faith helps, hope helps. So let's instill hope. Let's join our hands together to ensure that every individual in the world, howsoever far he or she may be, does not feel isolated, for each life is precious. Thank you so much. If there are any comments, any suggestions, any questions, please feel free to ask.
Thank you so much, sir. Thank you for your incredible talk that you have delivered today on this World Mental Health Day, which I suppose is very important for all the viewers who have heard us today. So thank you so much for that, sir. We have received few questions, sir. With all your due permission, I would like to put across those questions to you.
Please do.
Yeah, the first question is, what is your recommendation for the treatment of perimenopausal depression?
Hello.
Yes, am I audible? Hello?
Hello.
Hello? Sir, am I audible?
I didn't get to hear the entire question.
I'll repeat the question again, sir. The question is, what is your recommendation for the treatment of perimenopausal depression? Can you hear me now, sir?
Absolutely, loud and clear. Go ahead.
Okay, so the first question is, what is your recommendation for the treatment of perimenopausal depression?
Yes, I'm listening. Please tell me the question.
The question is, what is your recommendation for the treatment of perimenopausal depression? Could you hear the question, sir?
No, I couldn't hear the question. If you could come again with the question.
Yeah, I am repeating the question. Am I audible?
I again can't hear you.
Sir, can you hear me now?
If you could place the question on the chat box or somewhere so I can read it, because I can't hear.
I'll do that. I'll do that. I did that, sir. I did that. Sir, the question is there in the chat box.
1 second. Let me just cross check. I can't see that. Can you repeat the question for me, please?
Sure. The question is, what is your recommendation for the treatment of perimenopausal depression? So now can you see the question?
It's not visible on the chat box. I'm just trying to see that. I can't see this. Rather, I've sent a question saying, please send the questions. That is a request from my end. But I can hear you now, so you can tell me the question.
The question is, what is your recommendation for the treatment of perimenopausal depression? So actually, at your end, the network is too bad. You are disconnecting and connecting again and again. So that might be possible. Because of that, you're not getting the questions, because I have updated the questions twice. I'll repeat the question orally once. The question is,
please do.
What is your recommendation for the treatment of perimenopausal depression? Could you get the question, sir?
I couldn't.
I'll repeat it again. What is your recommendation for the treatment of perimenopausal depression?
Okay. This is very important question, and thank you for asking this to me. there are certain phases of life when females are particularly more vulnerable to depression. Perimenopausal depression is one of them. And in such cases, SNRIs do help, particularly medications like desvenlafaxine in low dosages work well for these patients. Again, one has to basically also understand the am I audible?
Yes,
Am I
sir, you're
audible?
audible now.
Yeah,
You're audible now.
Yeah, sorry for this inconvenience and the technical snags in between, but just to keep the flow on, uh, a lot depends on the patient's profile. So if the patient has an obsessive mindset or is a ruminator, thinks a lot, is an overthinker, then perhaps an SSRI is quite useful. But for perimenopause, like I said, we have to be careful. And there are certain side effects, merits and demerits of using any medication, because no medication is an ideal medicine, isn't it? They all come with their own side effects. So we should be careful about that, particularly in elderly females with too many physical comorbidities. We should be careful with respect to the syndrome of SIADH, syndrome of inappropriate ADH secretion, with the use of antidepressant molecules. So we should be a little more careful. In such cases, I do tap for blood sodium hyponatremia in such patients. So we should be careful that end.
Thank you, sir. Thank you for answering that question. We will take the next question that we have received. And the question is, what is the management of comorbid depression and anxiety in chronic obstructive pulmonary disease?
Okay, so here we are looking at different comorbidities. Depression and anxiety is fairly comorbid, right? But if we have patients with chronic obstructive pulmonary disease, we should also try and treat the underlying reasons, which perhaps gradually, kind of making them quit their smoking. That's something that we try to help those patients with. That's one area. The other is depression and anxiety. Just like we treat depression and anxiety in any other patient, we should be a little more careful here, because we are talking about obstructive lung disease. So we don't want to subject these patients to anticholinergic side effects. So tricyclics are better avoided in such patients. We prefer the use of SSRIs, medicines like escitalopram in a low dose. You may be having. SSRIs, I would say, would be considered in such cases as comparatively safer. And out of those SSRIs also, escitalopram, because of least drug-drug interactions, as one of the choice.
Thank you so much, sir. Thank you for answering that question. We will
And
take the next.
And just to add on a little to the previous question, for anxiety, we prefer not to give too many benzodiazepines here. One, we should avoid a cocktail of benzodiazepines in any patient, because just like you don't club wine with whiskey, with gin, with vodka, similarly, you don't club alprazolam with clonazepam. Benzodiazepines, because we don't want them to be subjected to the risk of sleep apnea. The third thing is, many times I've used buspirone in a low dose as an anti-anxiety agent. It's a 5-HT1A partial agonist, and it does help such patients. Patients with asthma, we cannot use beta blockers particularly propranolol. So I avoid the use of propranolol in such patients.
Sir, am I audible? Hello? Sir, am I audible?
Yes, you are.
Thank you so much, sir, for answering that question. We will take the last question that we have received. And the question is, please elaborate how to identify and manage depression in patients with coronary artery
I
disease.
couldn't hear the last part of it. You said, please elaborate, and then your voice vanished.
Please elaborate how to identify and manage depression in patients.
I'm waiting to hear that.
Hello. Could you hear me, sir? Hello. Yeah, am I audible now?
Now, yes.
Okay. I'll repeat the question. The question is, please elaborate how to identify and manage depression in patients with coronary artery disease.
Okay, this is a very relevant question asked. Now, when we are talking about coronary artery disease, there are underlying risk factors also, isn't it, which need to be looked into. One of the cardio-safe medication is sertraline, which is an SSRI. Low dose of escitalopram can also be used in such cases. So SSRIs, I would say, would be a better choice in such individuals who have coronary artery disease. There are certain medications which we have to be carefully monitoring if they are already taking any particular medication, because we cannot stop and start medications very quick in psychiatry. So if at all they're already on any other antidepressant which has anticholinergic side effects, or which is causing a lot of sedation, or perhaps is increasing their lipids or disturbing their sugar levels, then we need to gradually taper off those medications and put them on safer salts. Like I said, sertraline will be a choice. Another choice would be escitalopram in such individuals. So was I audible?
Yes, sir, you were audible.
And I hope I could complete that. Yeah.
Yes. Yeah. Thank you so much, sir. Thank you for answering that question. That was the last question for today's session. And at the outset, I would like to thank all the viewers who were here with us and who have listened to the whole talk of yours and have put up their questions to us. So thank you to all of them. And with this, we would like to conclude the session here for today, sir, with all your last comment.